Before we get started, I just want to say thank you for listening, for supporting the show, and for being part of this community. This upcoming episode is a special one. I had the chance to sit down with Chris Hutchins, and he was an incredible guest. Chris shares firsthand story of navigating the COVID pandemic in New York City as part of Northwell Health, what it was like on the ground, the pressure on data and analytics teams, and the decisions that truly mattered when everything was on the line. What makes this conversation especially relevant is how those lessons carry forward. We talk about what the pandemic taught us about trust, speed, and impact in data, and how those learnings should shape the way we deploy AI across the enterprise today. Let's get into it.
So what have you been up to, Chris?
Sure. First, thanks for having me on. It's great to be able to reconnect with you. Like you said, it's been 5 years. But for those who don't know me, I've been in the data and analytics space more recently and dealing with some AI. Better part of the last 30 years, which is crazy to be thinking about at this point. I never imagined at this point in my life I'd still be dealing with data and analytics, or much less than I think I'd be dealing with AI. But so I started my career back in New Hampshire. For a number of years, I worked for Dartmouth Hitchcock Medical Center. For another 15 years after that, I was at Mass General Brigham as a deputy CIO there for several years, and eventually got a call to go to New York and join the team at Northwell Health. I was the chief data and analytics officer there for just a little under 8 years, doing a lot of interesting things there. You mentioned the pandemic. To say that was an extraordinary time would be an understatement. For those of you who don't know, Northwell treated more COVID cases than any health system in the US, which is impressive, but not something you want to aspire to, unfortunately. But I did get to work with an exceptional group of people on every level. It was the efforts were just truly amazing and heroic. So I'm very, very happy to have been part of that and gained a lot of respect for so many people doing so many different kinds of jobs. It's astounding. Back in 2023, I was offered a role here in Tennessee. So I was working for LifePoint Health for a couple of years. And back in the spring, made the choice to launch my own consulting company. So I'm sure if you've seen any activity from me online, it's really under Hutchins Data Strategy that I'm doing a lot of advisory types of things. Surprisingly, there's been a lot of inquiry coming from founders and CEOs as well as investors that are trying to figure out, how to navigate the health systems and what kind of solutions are going to be meaningful to help them solve some of the workflow challenges that they have. So that's been my focus for the last 6 or 8 months, and I guess time's flying. It's probably more than that now, but anyway, that's me in a nutshell, so to speak.
Yeah, thank you for that introduction, Chris. And as we look at that crazy time, COVID, obviously, we had that one last trip to Florida. It sounds like right before the everything hit the fan. And how would you describe that from your perspective? And maybe like if you have a story or two of how you were able to get things that probably would have taken months or years to do, probably in a very short amount of time.
That's an excellent question, and it really is remarkable. To your last point, where we used to take months to do things, having to turn on a dime, which was really essentially what ended up happening. It was crazy. But just prior to the pandemic, I had been working with a team of people to introduce a new data warehouse vendor into the environment. Really, a data lake was the objective. There was a pretty significant contract that was on the table. The organization kind of was slow to go through the process of assessing the technology, and also a little slow on the contracting side of the things. In a large health system, I had no idea just how big things were until I started to go through a process for getting approvals. It was very, very time consuming to get a contract. But anyway, when the pandemic hit, that was basically the end of all activity non-related to really taking care of the logistics and all supporting the clinical teams that were involved with treating COVID. So it went from a point in time where, we were talking just before that in Florida about data visualization. There's a lot of focus on what's effective, what's not. How do you deliver meaningful value? It's not just about giving people their dashboards. I remember some of the things we even talked about back then were people wanting a dashboard because someone else had one. There was definitely that kind of a feel beforehand. There was a lot of nice to have types of things that we would do more often than some of the larger types of projects. But fast forward to the pandemic, then all of a sudden, a whole new set of priorities and a whole new approach to actually making decisions on what we were going to execute on. One of the things that was really, really profound, one of the data architects on the team had this idea of creating an infrastructure that could support the inpatient activities of the health system. There were 23 hospitals involved at that point in time that were part of the organization. The concept was we're in the middle of a massive, massive population center, but the potential for over 6 million patients needing care at some point in time. The critical thing was it was difficult because the data set was so large to curate data in a way that you could actually see the entire patient record for someone when they're admitted to the hospital. It's organizations that don't grow by acquisition probably don't suffer from this very much. But because that's how the organization grew, there was every EHR known to man in that health system. We had over 70 of them. Some were the same vendor solution, but different instances. And it was always a painful process to onboard one to get it into the enterprise environment. So the idea was we're going to create this currently admitted patient index. And what that did is anytime someone was admitted or was about to be admitted coming through the ER, their record number was attached to this index. And at that point, we would go back into the records and we would pull all of their history forward into this much smaller data set that was finite and manageable. It was indexed. So the maximum number of beds we actually could have had at that point in time was probably, I would say, maybe 4,000. I'd be off on the number. I'm sure I'm not precisely correct. But anyway, having that in place was actually unbelievably helpful because once the pandemic hit, we already have something in place to really help the organization to monitor what's going on. And they can look and see where there's growing demand in any one of the sites where they can actually be, proactive and address scheduling if they needed to. But there's just a few little things that we had to add to that index, things around the ventilators, and we had a couple different things we added to track PPE being issued to team members, things like that. It was actually really a fortuitous thing that was already in place at the outset. So we started having 2-a-day huddles, one in the morning, one in the evening. We had to shut down all other pipelines essentially. And we had to really tighten access controls because it was so important that everyone was getting the right information at the right period of time. It was really a crazy time because there were periods where we would be working on some kind of a metric or doing some analysis on when we think we're going to hit the plateau and we might actually see a decline in admissions from COVID. Intake valves were wide open. We were seeing so many cases come in that overnight a conference room could become an ICU. That seems ridiculous, but that's exactly when it ended up happening. We actually were seeing more than 1,000 or 1,500, I think, overcapacity is what we ended up with at one point in time. So it was really crazy. And I remember everything would stop somewhere between 10 a.m. and noontime every day because the governor would come on TV. And it was pretty regular that we would get instruction in real time. Because we're a big health system, our CEO was in frequent communication, and he was actually getting tasked with things to support what the governor was trying to get done statewide, which is remarkable, but this was happening in real time. We would be up at night, 10, 11 o'clock. We needed to get some data moved around. that typically it would have taken me months to navigate and get approvals with the human resources department. But in that instance, executives were calling other executives, bringing them onto one of our calls, and they were approving data movement in real time. I'd never seen anything like it that moved at that pace. Another great example is we were always being stonewalled when we were trying to get data from the state, from the Department of Health, for really legitimate reasons. But there were so many restrictions on how it could be used because they were just concerned that it would be used for, an organization to try to get some sort of competitive advantage or something. I understand that. But there was a period of time where they really wanted some good predictors of where there's going to be potential outbreaks and things like that. And one of the things that we asked for was we needed at least once a day, we needed an update from the state with regard to vaccines. I mean, how many people were getting their vaccinations and in which locations, so we could see where the volume was coming from. So many different things, but it just changed the types of analytics that we're dealing with. I never even knew anything about serology testing, but that was actually a thing. We had to spin up an index to support serology testing for employees, things that literally would have taken months just to get an approval. I mean, we were having to do those things almost overnight. In some cases, it was less than a couple of hours that we'd have to respond to things. But yeah, very, very different time, but it has changed things for good. And, it was probably a week or so after we saw the decline in admissions. I think that was around the time that I heard from the CIO that they wanted to meet to revisit the conversations around the data lake, because they suddenly realized just how valuable the capability was during the pandemic, and they wanted us to go further with it and really increase the level of visibility they had into the operations of the health system, and to start using the data and the analytics to drive a lot of decision making around staffing, both from an hour-to-hour standpoint within the facilities, but also even looking at it from a long-term lens where we're looking at clinician burnout, nurse burnout. Those things really got pretty crazy during the pandemic, because I don't know how everyone else's experience was, but our doctors and nurses were burning the candle at both ends. They were just working crazy hours. They couldn't take a break. They couldn't take vacations. They couldn't even go home and hug their kids. Back then, it was just a really, really difficult time, but that's where it was pretty amazing just to see how the data and analytics changed in the way that they're being used and the way they're even thought about. And I don't think we've looked back since in healthcare. Any organizations I've been a part of, there was really a significant pivot to use data and analytics in a much more meaningful way, not for, to have a nice dashboard, but to actually have the capabilities to manage the business more efficiently.
Yeah, I find it incredible that, we moved from this kind of like, I think, mentality in the healthcare sector where data and analytics was always kind of there. And then we come to this like really critical life and death, basically, moment. And everybody says, oh, wait, we really do need real time data. We need those dashboards that are not just there for, I might have a question once in a while. It's like, no, we need to have somebody monitoring this thing like every minute of every day. And I think was it Johns Hopkins that had the big dashboard on COVID across the US and the world? And that was like for a time, that was like the most visited website in the world, I think. And I remember looking at that stuff and I'm like, well, that's an example of like the data team just coming together and like meeting the moment. And which I think what you're describing is kind of similar, like the Northwell, probably like one of the major healthcare or institutions that had this huge, response and impact during the pandemic. And moving along. So what do you think is the lasting legacy of that? Do you feel that now we're obviously also in a changing? I feel like pandemic was like a signal. Like I think it was a signal to the industry that like same way that we were doing business was not going to cut it, right? And then now we're in that age of AI, and now anybody can build a dashboard, right? Anybody can build an application in Claude or OpenAI or Gemini or whatever. How do you feel that became a catalyst, and then where we are now?
Well, it certainly got us in a position to where we're able to respond to things much more efficiently. There's no question about that. And it did highlight the need for much better data curation than we had done previously. Organizations tend to be much more comfortable spending a lot of money on some technologies, but it's always a difficult hill to climb when you want to get them to invest in improving the quality of the data. But as you know, with the prolific rollout of AI capabilities, obviously most of us started with ChatGPT. There's a growing need for data curation, and when organizations are onboarding a new hospital or a new provider group, getting that data, for lack of a better term, shoehorning the data into your model because it doesn't look exactly like all the other data that's in there. There's a big lift to do that, but the value of it is undeniable. When you have that there, you can actually see what's going on, to your point, in real time, which is important when you're dealing with emergency care for sure. And in the case of the pandemic, you really needed to understand not only where your patients were, you also needed to understand from a staffing standpoint where your team is located, where they're traveling from. Is the place they're traveling from seeing a spike that we need to be prepared to address? Do we need to um, move non-critical cases out of one of our hospitals and move them to another one that's not seeing so many COVID cases? I mean, there's just a lot of things like that. But the pace now that we're seeing is probably at least twice the velocity that it was prior to the pandemic. And a lot of it was because we had to learn how to do things faster. And I don't like to use the word, and I haven't for a long time, but we were kind of calling things COVID speed. And it just proved that we can get out of our own way when we need to. And we've not really been good at that historically. But now, when we're dealing with all this AI stuff, it's really, really important to make sure that you've got your data very well organized and as clean as you can possibly get it, because now there's just this massive consumer movement to use AI, even as a patient, to figure out how serious are these symptoms that I've got, or what are they? Do I need to really be seen, or do I just need an over-the-counter solution or whatever? But it's becoming part of everyday life, and so it's forcing us to really start to address some things in the governance space that we've not really addressed before. That's going to be a topic that's going to be hot for probably all year. There's definitely some interesting cases that are starting to rear their heads because of the way some of the AI technology is being used. And probably the one that's most significant is the ambient listening capability, which actually is pretty crazy when you think about how we have year by year with the electronic health record, we have just added more and more data elements that a clinician has to actually enter. We just added hours to their day. That's what we've done historically year over year. Having the ambient listening in the room now as a patient and a doctor having their conversations, having that transcription being done in nearly real time, and the physician's only got to do a review at the end of the visit. It's a really big win in terms of making the visit more comfortable for the patient, because the doctor's not splitting their attention between the screen and looking at you as the patient. So there's definitely an improvement there. And then there's, the time that we're giving back so that the encounter can actually be primarily just the engagement between the patient and their provider. But then also, I don't know how folks experience things today, how different it is, but there was a time you could count on being in the waiting room for a very long time before you could actually see your doctor, and what time your appointment was just didn't really matter anymore. That was a lot of result from these additional layers that we kept putting on. So ambient is, I think, probably the one I'm most excited about the potential for. But we also have to deal with the unfortunate realities of hallucinations, which people are going to hear a lot more about that too this year. I'm sure of it, because there's a lot of work that we've got to do these things responsibly. And some of it's the data that's there. And it's the quality of it that's leading the witness, I guess is a good way to put it. We don't want the AI to necessarily leap to conclusions, but it tends to do that.
Yeah. Yeah. So what do you feel is the answer to that? Like, I feel like the genie is out of the bottle, obviously, right? We're seeing, I've been personally using, ChatGPT now for like probably the last 2, 3 years. And, last night I used Claude to summarize my family's health data. Like literally like took a dump of all the EMR data, FHIR data that came out, dumped it into Claude and had it create a medically accurate, basically it was like a complete report of your health for me, my wife, my two kids. And what it did was honestly better than anything I've seen in any patient portal over the last 10, 15 years. Like Marshruff has nothing on what this thing did, right?
Right.
Now, do I trust it? That's the main question, is that I feel like everything at the surface looks accurate and perfectly well, right? Like, and it
Hmm.
does it in a way that it's very easy to consume and understand.
Right.
The visualizations are top notch, the numbers, the comparisons, it gives you citations. What do you feel like is the step that we need to go to prove to the patients that the data that they're receiving is clinically accurate? Is it having providers in the loop? Is it providers and patients looking at these things together, maybe as a, like a care team, so that the patients are not just doing this completely on their own, or maybe just having the patients share that back with their provider and have them say, yeah, this looks good? Or what do you think?
This is going to be an interesting thing to navigate. And it's like you said, the genie is out of the bottle. Just in what you just described that you did for your own household. One of the things that's always a concern to me, and it's because of my own experiences. The way I started to use ChatGPT myself was I built my own custom GPT where I put like a whole bunch of things that I'd written into that I've, probably 10 to 15 years worth of stuff that I've written about, or any talks I've done, podcasts or speeches, just transcribing everything, getting it in there so I could use it as a reference point. And just doing that, I was able to suddenly recall things that today if you asked me, put me on the spot, I probably wouldn't remember. And that's probably the thing that concerns me about how patients might interact with these tools and make their decisions on their own healthcare, because I don't know what I had for breakfast sometimes. By 2 hours later, I don't remember that. Much less am I going to remember the specific conditions I may have had a decade ago that actually could be very relevant for a clinician who's trying to make a good call on what to do to improve my health or to prevent, some kind of a sickness. Prescriptions that I took along the way. I mean, I can't really, sadly, I'm at the point in my life where I have more prescriptions than I wish I did, but I can't rattle them off the top of my head. And if that's what is going to inform the models, is what we actually can recall, and it's not based on things that we have documented somewhere. I don't know if you've been seen in other places besides where you're living, but if you have, that data is probably not accessible very easily either. Over the next few months, I think you'll start to see some accountability structures being put together. And there's a real need for that, because the AI generated content that goes into the EHR from an ambient listening solution, for example, that is not covered under the oversight of the FDA. That data is not even considered HIPAA. It comes under the High Tech Act, because that the tool that's generating it is considered to be an administrative system. It's not clinical. So the minute a doctor signs off on anything that gets generated, the doctor is the only one that has any liability, or the provider, meaning that the organization is the only one that's liable. The technology company is not. OpenAI not on the hook for that. Anthropic, they're not on the hook for that either. This is an interesting dynamic, because if you are led to some sort of conclusion when you're interacting with these tools, and you make the wrong decision based on that recommendation, you've got no recourse unless a doctor prescribes something or diagnoses something. There's no liability there. And so there's a big vulnerability that's there right now. And there's a case in California currently that was filed last month. No, it's November. We're in January now, right? For the very reason that the patient was reading in their MyChart and come across this indication that there was a conversation was recorded in the exam room. The data was there, and it actually intimated that the patient had consented, and the patient was not aware of it at all. And so this lawsuit is going to be very, very interesting to see how it shakes out. But my suspicion is there'll be more of that, in probably some situations where there's potential for class actions. I mean, there's probably, I don't know what we're going to see, but this is an issue that we're going to have to grapple with and really do something to solve, because how many patients are going to go in there, look at it, and it's telling them the symptoms are not that significant. Here's a couple of things that you could do to help yourself, with its exercise or vitamins, or over the counter thing or whatever. And they don't go to the doctor, right? There's that side of it. Now, the other side of it is the ones that are going to be certain that they've got the worst case scenario and they're going to go to the doctor. And on that side, the concern's a little bit different, where you may have a patient that really doesn't need to be there, and there's not space for the one that does need to be there. We already have some capacity and burnout issues in the clinical space, where physicians and nurses are they're dealing with incredible workloads and expectations that they see more patients. So anything that we do to make them more efficient with AI, there's this expectation now all of a sudden they've got more capacity, they need to see more people. So that's going to be a thing that we have to watch. But probably the bigger concern is when Dr. ChatGPT says, you're good to go, don't worry about this, whatever, and you don't go. That's going to happen enough. I'm certain of it, that there's going to be physicians' offices that start to see a further reduction in the volume that they're seeing. So who's going to benefit from that? Well, the insurance company is still collecting premiums, but they're going to pay less claims because they won't have claims to pay. That's going to be an interesting dynamic. At what point does that bring the cost down? Because it should, theoretically. But the balancing act between what the physician gets involved with and what the patient's doing with the AI, we don't have any control or visibility into it on the provider side until the patient makes us aware. And so, not quite sure what the answer is going to be, but I've had some conversations with some clinical folks that are thinking about coming up with some sort of an accountability structure so that we can at least start leaning in and trying to solve some of these things proactively. We're a little late to be proactive, because that's probably not even the right way to put it. But when I say proactive, I mean, let's start trying to get this stuff figured out before our governing bodies, from a regulatory standpoint, start to weigh in and understand that if we want to do something to make sure that we're getting it right, we need to figure it out with the clinicians directly involved, make sure that we're influencing it and it's not being done to us, because that's what the regulatory approach typically ends up being. And it's not being designed more often than not by the people who really know best how to do that. I don't mean any disrespect to any profession, but I don't think politicians and lawyers are the ones that really ought to set the standards for how we use it for critical care.
Yeah, absolutely. And I think with any AI, as now we're getting to a stage where the benchmarks are really critical to evaluate the efficacy. Just like there's
Mhm.
benchmarks that every new LLM model that comes out, there's a new set of benchmarks where it has
Mhm.
outperformed the previous model, and those are widely shared. But I think that there are certain benchmarks that exist in in healthcare, in the clinical space.
Yeah.
I think OpenAI had this clinical bench, and there's Gemini had this assessment of basically how well does it do on a resident exam, and all these other things. But I think we really lack benchmarks from a consumer perspective, and also how this healthcare AI is evaluating basic you know patient questions like, I have high cholesterol. Do I need to start in a statin or not? And what are the things that go into that? Right? It was like a simple question, but
Mhm.
I did a search on that, and looking at all the different studies and looking at all the different things that go into that. There's a lot that a clinician has to look at, right? There's like
Right.
3-4 year history, many different things that may seem elementary, but first of all, if you don't have all the data to consider that,
Yeah.
if you're sitting with your primary care physician, they're asking you all these questions, right? Is the
That's right.
AI asking you all these questions? Like, and where are the benchmarks, right? That we can see
Mhm.
where they're evaluating this against the standard set of. So I think there's a lot of work to do as the AI use cases get more concrete and more
Mhm.
specific on every area, outside of our everyday life, essentially. So,
Right.
so do you feel like that's the answer, is like having better benchmarks and being able to prove, right, that
I
they're
think
performing?
I think we definitely have to have some better benchmarks. There's no question there. But you hit something that I think is a really important thing, as well as missing data. This is one of the problems that AI is not ever going to fix. So as a physician looking at a patient, The physician's always wondering, what is it that I don't know, and is it important? That question is still going to be there with AI. Hopefully, we're at least processing more information and much, much faster to provide any indications that would be important for the provider while they're determining what protocol to follow for a patient to get the best outcomes. But the risk for me is for bias is really not the nefarious stuff that is easy to think about. It's what is the impact of not having enough information? Because if you're using, like you mentioned, ChatGPT, if you're using that yourself, you definitely have these occasions where you see it'll try to create an illustration for you that you're not asking it for. This is the kind of stuff that makes me get concerned, because if you're not paying attention and you don't know that it does this, you may consume information thinking that you're getting an accurate set of recommendations, and that may not actually be the case, because these models actually operate in a way that they assume you've given them enough information to answer your question. And if you don't know to ask the question, it's not going to figure it out and ask and say, you should have asked me this. It's just not going to do that. So this is really one of the bigger concerns that I have, is what's missing that's really, really relevant. And oftentimes it could be context, and probably more so than anything else. The lack of context is probably going to be the bigger issue when it comes to how the models actually perform. So good example. If you are a data scientist and you're being offered a job, you go into ChatGPT, and it knows I'm logged in as Chris. It's going to assume, okay, Chris is probably a male, but given the spelling of his name, he should be asking for $400,000 a year. But if it's Christine, it's looking back at the data and say, you should be asking for 290. Two different answers based on historical facts that are actually in the models, without the context that we have made policy decisions and legislative decisions that require equity. That's one such example where the data that it's being connected to is causing it to fast forward and predict what you should do next, suggesting what you should do next. This is where we're going to have a lot of challenges with it. And people need to understand this. We have to educate people, make sure they understand what are the guardrails and guidelines that you need in order to make sure that you're using the things in the way that is safe to be used. Answering yes or no questions, I don't think I'd be comfortable with that even. I mean, it seems basic,
Yeah.
but you really have to be smart about what you're doing, and the context means everything. You reporting that your blood pressure is slightly elevated. Well, ChatGPT doesn't necessarily know unless you've told it that that's actually a normal level for you. And it might tell you to go to the ER, and you don't need to go to the ER. It might be controlled, but without the context, without understanding what's unique about you, it's going to give you advice based on this composite model of what an average person that is in your demographics actually has going on. The only problem with that is, as we've built incentives and disincentives for quality of care, well, everything's based on that average, and not one human being that fits that model. They just don't. And everyone's unique. There's so many different factors. You and I can come into the same condition, be given the same prescriptions, and we get two completely different outcomes, because there's different things that are contextually there in one case that are not there in the other. And the models don't know that.
Yeah. Us specifically, I think, coming from the data and analytics space, you almost have like, I don't know, I find it very scary that which is going to happen every year. Like I've been copying and pasting my lab data from my chart into ChatGPT or any other tool.
Right.
And I just know inherently how many issues there are with that data, right? And just seeing it from so many different, sources in the EMRs and lab systems that are all disconnected, disparate.
Yep.
They don't all talk to each other. They all have different levels of terminology, accuracy, level of curation that has been attempted by one particular organization versus the next. How do we reconcile that? Because ultimately the LLMs are trained, I think they're trained inherently to just take data for what it is, right? Like they're not, if I tell it, I am Gene and now I am Gene spelled something else, they're going to start calling me by this misspelled new version of Gene. because
Mhm.
that's what I told it to do. And then at the same time, if any data I feed into it, they're going to take this, code or description of a code or whatever, and they're going to take it for what it is, even though that may be
Mhm.
completely wrong, right? It can be
Yeah.
completely like just, which is an artifact of the system. And I'm not saying in any way that we shouldn't use AI and that we shouldn't
Mhm.
learn. I think that we should just be mindful of that the level of data quality in healthcare is, to those that have been working with it, is extremely scary
Mhm.
proposition to just open that up to all the people that are not aware that there could be issues with their
Right.
particular health system's data.
Yeah, you touched something there too that I think people need to be mindful of. If you're taking data from copying something out of your My chart and you're putting it into those models, if it's one of the browser-based models, that data now is out there beyond the firewalls that you're protected from. So when the data is in the EHR, it's behind a firewall. When you copy and paste it, you've now caused your PHI, your personal health information, to be put out there in a public model. That doesn't mean everyone knows how to get to it, but it has now left the protection of HIPAA because you've moved that data and you've put it yourself. You've moved it to where you own liability for it now. People aren't going to think that way. But that's exactly what happens. The minute that data gets put into one of those models and it's going outside of your organization, if you happen to be in healthcare, but yes, it's your information. You have the right to use it however you want to. But you also have to understand when you do that and you're putting it out there, you've changed the dynamic. I don't know that health systems are going to be terribly upset with the liability risk getting reduced, but people need to really be mindful of that. You don't want to trust everything to a machine or to technologies. LLMs have flaws because they're built by people who also have flaws. I think one of the funniest things for me is that we don't recognize that AI means artificial intelligence, meaning it's not real intelligence. I think that's something that is elusive. We get really, really excited about new pieces of technology, and before long, we're trusting it way, way, way too much.
Yeah, I think like I've been hearing more and more. People call it reasoning, not intelligence. So I don't. There's
Mhm.
a very thin line of what makes us human. There's been a lot of interesting interviews, conversations that I've heard about. People are excited about the super intelligence, AGI,
Yeah.
that we keep hearing is coming, and people can't really even explain what that is, right? Because it's like,
Right.
what do you mean? What is AGI, right? And if you think about it, what makes us human is the things that you can't recreate, right? You can't give this machine ability to reminisce, have memories about things that actually happen, to dream, to all these kind of things that makes us human. Machine doesn't have that, right? So you don't have all of those other things that can inform that context and how we
Right.
respond. What do we feel? What do we feel? Right? Do you agree with that?
Yes, and you're touching another thing that people probably are not thinking about this. The way you prompt is also training. So when you're prompting the tool that you're using, your line of questioning, your thought process, your anxieties, your fears, things that aren't necessarily ever going to be part of a conversation you have with a doctor, you're giving that kind of information to a technology company. So OpenAI is going to not only understand the conditions that you can verify, it's also understanding your state of mind. Boy, he seems to really be concerned about X, Y, and Z. I can pick that up because of all the prompts. No one's talking about it, but that's useful information for someone who might want to be selling you something. And I, I, I'm not one to just go ahead and say, okay, when someone says, trust me. And I don't think any of us should be that way. And it's not that these people don't have the best intentions. I don't think that that's, something I would even argue about, but it's the unintended consequences stuff, like the fact that my state of mind now is going to become available for someone who wants to exploit me to sell something. That's a very real possibility. There's other even more nefarious things that are possible. I'm certain of it, but just for all intents, for the conversation, I think that's just something that we have to be aware of. We've got to be careful about what we're trusting. I mean, think about, when was the last time you were going someplace you'd never been and you just blindly put in the address to a Waze or whatever app you like to use for navigation, and you just trust it and you go where it tells you to go. I mean, we've been doing that for a long time. What we're talking about now with the introduction of AI into the healthcare space, we've got to be very, very aware that it does not have the ability to make a judgment call. It doesn't have
Yeah, and I
context
think
unless you give it context.
yeah, and I think that's the other piece we're missing, right? Like, so we're kind of like using the Waze analogy, like we put in the destination where we want to go, or rather, the machine is telling you where you want to go, but also we can't necessarily get there because that's outside of the, there's not like pressing the OK button and it routes you to your destination and it
Mhm.
gives you the directions. I think we just open up like the level one. So the level one is the, just connecting and reasoning
Right.
about healthcare and but then we have like level two, level three, which is taking actions and being able to schedule your provider and appointment and integrate this into all of the kind of the ecosystem, right? To make it really better in all ways. I think you can agree with me when you say like the current system has failed in making this all easy and simple. And that's why the costs are the way they are, is because uh, you know, everything's done not for the patient's benefit necessarily a lot of
Right.
times. So I think that there's a great opportunity. Do you feel like that level two, level three, where we are getting to the full, schedule me with this specialist, show me all the specialists in my area, give me the, the appointment, prepare all the things I need to make that a smooth appointment, and then actually get care and schedule care afterwards, all through this one kind of experience? How far away from that, do you think?
That's a That's a difficult one because there's so much of a gap for interoperability currently until we can fix that. I don't know that we're going to be able to get to where we want to go. Organizations that have just one EHR and it happens to be, Epic or something or Cerner, whatever people choose there. If you only have one of those, one scheduling system, you can do that pretty effectively. But if you're an organization that's been growing by acquisition and you have multiple different versions of these applications, it's just a really difficult lift, honestly. And there's probably going to be some capabilities, and I actually know of some that are actually out there now that can help accelerate the ingestion and the standardization of these types of data that will allow, what you're talking about is really efficient scheduling and having it, be accurate. But that just the scheduling piece alone, it requires pretty significant efforts of a team of people to make sure that the scheduling templates are kept clean and accurate. They have to account for different times a year. You've got to have a certain amount of slots available for sick visits that patients that need to be seen urgently. There's just a lot of things that have to be done extremely well for that to work. And it's just very difficult when you're on multiple different systems inside of a single organization.
Absolutely. That's probably one of the reasons why scheduling in healthcare has not been solved, I
Mhm.
would say. Just a lot of definitely initiatives that are taking place right now to try to figure that out. But I
Right,
think we're very far from just having an easy, simple way to schedule yourself across any healthcare provider in the country.
right.
Hopefully we'll get there. All right. Well, thank you, Chris. Great conversation. I would like to give you a chance to offer our listeners a way to keep up with what's going on with you. And I think you said you started your own podcast as well.
Yeah, so thanks for that. Probably the best way to get in touch with me or to follow what's going on, you can find me on LinkedIn. My profile is under C Hutchins underscore healthcare, but you can also find me at hutchinsdatastrategy.com. Um, it'll give you links there to all of my content, my newsletters, press and media appearances, things like that. And there's a tab in there for the podcast for the Signal Room. There's both audio and video links there to all the episodes. So if you're wanting to hear a whole bunch of people much smarter than me, the podcasts are really good for that.
That's my line. So thank you very much for coming on my podcast. And people check out Chris's podcast and his Chris Hutchins Data Strategies as definitely one of the most well-respected individuals in the space, I think. And it was a pleasure, Chris, to talk about this and to hear some of these stories.
Well, thanks so much for having me, Gene. It's always a great conversation when we get together. We got to talk more often, my friend.
Absolutely. I would love to. All right. Well, thank you very much.
Thank you, man. It's great.